When we have swallowing problems, that is called dysphagia. I want to give you a definition of what dysphagia is. Dysphagia is when we cannot easily transfer a substance from the mouth to the stomach. And because of that, we fail to maintain hydration and nutrition, and there may be a risk of choking or aspiration, which is when that food goes into the airway, into that windpipe. These impairments, these difficulties can happen at any of the 3 stages that we talked about. It could be during the oral phase when we are preparing the food. It could be during the pharyngeal phase when we're actually actively swallowing that bolus, or it could be in the esophageal phase when the food is trying to make its way to the stomach. Aspiration is when a bolus enters the airway and can travel into the lungs. If aspiration happens once, probably not a big deal. But if it happens a lot over time, that is when we can get a risk of illness like pneumonia, and it can become dangerous. It's important to remember too that swallowing is dynamic. And so a child or a person may not have any signs of difficulty with every swallow or every type of bolus. It may be that a child can pretty safely consume and swallow liquid, but not solid food. So it is not an all or nothing thing. And yes, swallowing disorders, dysphagia, can be caused by not having strong enough muscles and not being able to coordinate closing off those valves. But it can also be caused by so many other factors that might prevent a child from even being willing to put the food near their mouth, right? So we will talk about all of those other factors next. Okay, what are some of these factors in charge? We know that a large majority, up to 90% of children with CHARGE syndrome, have been reported to experience some form of feeding difficulty. It may be a mild difficulty or a more severe difficulty. CHARGE is a genetic syndrome that children are born with. So let's talk about what are these characteristics that are often present right at birth that can affect feeding and swallowing. These are known as congenital problems, things that children are born with. Many children with CHARGE are born with cleft palate. That is an opening in the roof of the mouth. And in babies with CHARGE, when they have that opening in the roof of their mouth, they are usually not able to suck properly, whether that is with a bottle or at the breast for breastfeeding. When we aren't able to close off that opening between the mouth and the nose, that affects the pressure system we need from valves. We are creating an open valve in the roof of the mouth, and now the pressure is messed up, right? And so babies may struggle to suck to get their nutrients. This can be a common problem that children with CHARGE are born with. Another one is choanal atresia, and that is when the nasal openings are blocked, and that can cause difficulties with breathing. And we know that breathing has to be coordinated with swallowing. And in young babies, they have to coordinate breathing and sucking. So these can be some pretty significant problems that babies with CHARGE have right when they're born. Here's a picture of cleft palate. On the left, you see that opening there. So on the left is an example of cleft palate. On the right is an example of a normal palate. When we have that opening, now a valve that is normally closed off is now open, and therefore we get difficulties. With choanal atresia, we see that the nasal airway is blocked, and therefore it is harder to breathe out of the nose. Okay, any breathing issue can then cause a swallowing issue. Some other congenital problems may be cranial nerve dysfunction. So we have 12 paired nerves in the back of our brain that often may not function properly in children with CHARGE, and those nerves are very important for swallowing because they send information from the brain to the swallowing muscles, and they also send information not just to help the muscles move, but to help the muscles sense where they are, right? So we have the ability to move the muscles and the ability for the muscles and the tissues to be aware of where they are. The cranial nerves are numbered because there are 12. And there are some cranial nerves that are specifically really important for swallowing. We won't get into too much detail about what those nerves are, but just for your own knowledge, the important cranial nerves for swallowing are cranial nerves 5, 7, 9, 10, 11, and 12. And I'll show you a picture of them shortly. The last congenital problem that many children with charge are born with are heart malformations or heart conditions. And the heart is responsible for helping to pump blood and oxygen through our body. The heart and the lungs have their own system that works together. So any heart problems can lead to breathing challenges. And when we have breathing challenges, then we have more complications in coordinating breathing, sucking, and swallowing in babies. Here are the cranial nerves. So the most important ones are cranial nerve 5, the trigeminal nerve, cranial nerve 7, the facial nerve, cranial nerve 9, the glossopharyngeal nerve, cranial nerve 10 is the vagus nerve. This is a really big one because it is responsible for so many different things. Cranial nerve 11 is the spinal accessory nerve, and cranial nerve 12 is the hypoglossal nerve. This one sends lots of information to the tongue. So that one can be largely important as well. All right, and then here's a picture of the heart showing this connection to the heart and the lungs, known as the cardiopulmonary system. And any heart problems can affect breathing. Any breathing problems can affect safe eating and swallowing. Some of these congenital conditions, like cleft palate, choanal atresia, and the heart malformations, can be fixed with surgery, but often not right away. The baby may not be able to get surgery as soon as they are born. This means that charged children often have a very challenging start with their feeding experiences, right? And that they may need a feeding tube, either through the nose, through the mouth, or directly inserted into the stomach right away. Usually, the feeding tube is not directly placed in the stomach right away. Often in young babies, they are given a feeding tube through the nose, through the mouth, or maybe even with a needle so that they can get liquid nutrition that way. These charged children do not have an easy start with feeding because of some of these congenital issues. And so right from the start, they may not be eating orally. They may not be sucking on a bottle or a breast to get their nutrition. So right away, we start a path that may be difficult. And that might be necessary because there are other medical things that need to be addressed. So those were the congenital problems. Now let's talk about oral motor skills in children with charge. Here's another picture of a cute child who is working on their oral motor skills. So what are oral motor skills? They are the skills needed to suck, bite, sip to drink, and chew. We need enough strength, movement, and coordination of our lips, our tongue, our palate, our cheeks, and our jaw in order to carry out these skills. And with children who have charge syndrome, these types of skills are difficult. And the reasons for that are children with charge have structural differences. The shape and size of their mouth and face is different. They may have significant weakness. That means they don't have enough strength to keep their mouth closed or to move their jaw up and down in order to chew. These are just examples. They also might have incoordination, which means that all of their parts can't work together easily. So it takes a lot of coordination in order to safely and effectively and efficiently eat. As someone like myself who has normal feeding and swallowing, these are things we don't often think about. It happens pretty naturally and automatically for us, but in children with charge or in children that have medical complex needs, these skills can be really difficult because of weakness, structural differences, or incoordination. And because of that, it all goes back to those valves. They may not be closing properly or fully because of poor oral motor skills. Number 3, a common problem in charge is sensory integration. And what is that? This is when our brain processes input from our senses that gives us information about the world around us and the world inside of us. So I like to think of sensory information as these boxes on a conveyor belt, and they are all traveling to the brain. The brain makes sense of them. For example, if I put my hand on a hot stove, I immediately get sensory information that it is too hot. My brain pulls my hand away because it can harm me, right? So that's a more extreme example, but that is sensory integration. And when children have difficulty in this area, they may have an abnormal sense of smell. If you have an abnormal sense of smell, then lots of food may not be appealing to you. They have difficulty with textures, right? So for example, a child may not want lumpy food or may not want crunchy food. This can cause children to pocket their food in cheeks because they may not be aware and they may not feel that the food is stuck there because they're not processing that type of sensory information in the brain. The opposite of that is they may overstuff food in their mouth because they want to be able to sense that there is a lot there. And this can result in food selectivity or refusal, right? So only being comfortable or wanting certain foods or just refusing food altogether. So sensory integration, how we make sense of the world and how we make sense of our own body, can cause feeding issues. We are able to sense the world inside of us because that is how we feel when we are hungry or how we feel when we need to go to the bathroom. And in children with charge, those sensations of hunger and of having to urinate or have a bowel movement, those may be compromised or reduced. And we need those cues in order to help us eat and digest and then expel our food and liquid appropriately. Number 4, another common feeding and swallowing problem in charge is aspiration. Aspiration is when food or liquid or saliva travels down the airway instead of down the throat. So here we have a healthy swallow. We saw this picture before in purple. The food enters the mouth and goes down the throat and into the stomach. In dysphagia, sometimes we risk food going down this front tube, which is our trachea, also known as our windpipe, that leads into our lungs. Not good. So here's another example. Here's a good swallow. The food is going down that right tube. And then in an aspirated swallow, we have food traveling down the wrong pipe, which can be dangerous over time. Why is aspiration so common in charge? Well, it could be because children with charge often or commonly have a tracheostomy tube to help them breathe. And once we insert that tube, which is an opening into the airway, we now open another valve that is usually closed off. And children with tracheostomy can be at a higher risk of aspiration. There may be a history of airway blockages in these children. They may have that cranial nerve dysfunction. So those nerves in the back of the brain may not be functioning properly, and they may not be sending the correct information to the muscles and the tissues. So food is more likely to go down the wrong way when those muscles are not working properly. Or they may have poor oral motor skills, and that puts them at risk for aspiration. So if they are not able to prepare a bolus to be safely swallowed, then it might lead to events that follow where the food is then not traveling in the right direction. And one more point about that. In summary, children with CHARGE syndrome typically have very complex medical histories. So there are multiple variables that may cause or increase their risk of aspiration. It could be one or multiple of these things that are all contributing to an increased aspiration risk. All right, so another common problem is reflux, which is when food is coming back up. Remember that black arrow that was pointing down? We want food to go down, down, down to the stomach. We do not want it to come back up. But in children with CHARGE, they may have disruptions along that path down to the stomach that cause those valves, right, to push food back the other way. They may have some weakness in where the esophagus or the throat, the lower part of the throat connects to the stomach. And there is a valve right here that may not be functioning properly. And so we have what's in the stomach coming back up, and that can be uncomfortable. It can be painful. So if a child eats and then experiences this, they're not going to want to eat very often. So that is reflux. And then we have constipation, where a child is not able to have regular bowel movements and things are getting stuck. So it all goes back to the fact that swallowing is a series of valves and tubes, and it starts at the mouth and it ends down at the anus where we excrete our food. So any blockages along the way of that long tube, any disruption of those valves is going to cause feeding and swallowing problems or just refusal to eat. It's not comfortable to have reflux. It's not comfortable to be constipated. And if a child associates that with eating, they will just refuse, right? They will say, nope, not worth it, because I can actually go a long time without eating, right? Can't go a long time without breathing, but I can go a long time without eating. I don't care. I don't want to do it. Number 6, oral defensiveness. And this is the result of all of this difficulty. So to be orally defensive means I don't want anything near my mouth. I don't want food near my mouth. And when a child is defensive, right, to anything in or around their mouth, it's likely because they have negative associations with feeding. It could be that it is challenging, that they have these sensory-based difficulties that make it unpleasant for them. They may have gastrointestinal issues, things like constipation or reflux, and they just say no, right? There may be factors related to, you know, their ability to process visual information, right? And or the ability to process auditory information. Many children with CHARGE may not have functioning vision or hearing. And so that may make them more defensive depending on the supports that they have to be able to understand what's going on. You know, if you aren't able to see or hear well and someone is trying to touch or put things in your mouth, you know, unless there is trust there and unless the child is learned that that is safe, they might just push away, right? So those negative associations with feeding can be for all of the reasons we have discussed, right? All of the difficulties that may be part of these swelling issues can cause negative associations with feeding. And when things are hard, we don't want to do them, right? We get defensive. Now, some children may have a breathing tube or a feeding tube in their mouth and facial area. And so that can cause some defensiveness. You know, they may be more sensitive to things in this area because of that. Feeding was or still is hard or uncomfortable, and that is why they are defensive. Or maybe they don't have an appetite or desire to eat. And we will talk about how that can sometimes be caused by relying on a feeding tube, right? They might be full from tube feeding, and they may not understand why they can get any nutrients from eating by mouth, right? They don't associate hunger with eating by mouth because they've been reliant on a tube. It all goes back to breathing. As we know, safe, effective eating requires coordinating breathing and swallowing. And many kids with charge may have tracheostomy. They may have needed that whole incision in the throat to be able to keep an open airway for breathing. And when children have that open airway system, we now have another valve that is open that usually is not open. And so that can affect the pressure system and can cause weakness and therefore potential swallowing difficulty. Not always. It can be more severe in some cases than others with how difficult the swallow is. But most likely a child can be at a greater aspiration risk when they have this tracheostomy tube. So here's a summary of a lot of the feeding and swallowing problems in charge that I discussed. And I like how a lot of these are all related to feeding dysfunction and gastrointestinal issues. We talked about having those anatomical or structural abnormalities like cleft palate. We talked about delaying introduction to oral eating due to tube feeding and why that may cause feeding and swallowing problems. We talked about cranial nerve dysfunction. We talked about some difficult behaviors, right? Pushing away, being aggressive, because children may not feel comfortable eating or safe eating or may not understand the point of it. We talked about some profound communication impairments, limiting expression of symptoms, more so from a standpoint of impacting their understanding, right? So if they cannot see or hear and they cannot verbalize how they're feeling, that might make them not as interested in eating and it may increase the difficulty. We talked about how it might affect, charge might affect their sense of smell because of that cranial nerve dysfunction. We didn't really touch on brainstem dysfunction, but that is another part of the brain that may be damaged or may not be functioning properly in charge. And parts of the brainstem are responsible for coordinating swallowing skills. So we can get issues from that as well. And then really the fact that these children have a lot of medical needs, all of those medical issues may take priority over working on their oral feeding, right? And seeking out therapy, and that's okay. There needs to be a hierarchy, right, of what needs are addressed. So if there are more pressing medical issues that are more important than working on eating, we need to take care of those first, especially if those are breathing issues, because if we're not breathing safely and properly, then we can't really work on eating at all. That being said, many children